Good afternoon and welcome. My name is Kerry Conley. I am the Director of Programs and Services for the Scleroderma Foundation's National Office and one of the many organizers for today's event. Thank you for joining the Scleroderma Foundation's Virtual University Patient Education Fall Series. We are very excited to host today's event, Coping with Both a Pandemic and Scleroderma. Before we get started, I wanted to share some quick notes on today's event so everybody has a successful experience. If you are properly logged into the webinar, you should be seeing the slide on the screen and hearing my voice. If you have dialed into the event by phone, please turn your computer microphone down to avoid any sound feedback. If you are using a handheld device, you may be required to swipe right or left to view the full screen demonstration. Today's webinar is being recorded and will be made available after its broadcast. The Scleroderma Foundation in no way endorses any drugs, treatments, clinical trials, or studies referenced today in today's webinar. Information is provided to keep the listeners informed. Because the manifestations and severity of scleroderma vary among individuals, personalized medical management is essential. Therefore, it is strongly recommended that all drugs or treatments be discussed with the individual's physician for proper evaluation and treatment. This webinar is for educational purposes only. We encourage all attendees to use the question and chat feature opportunity on the sidebar. Team members from our national staff will be hosting a question and answer segment at the end of the presentation. So let's get started. I am happy to introduce today's speaker, Dr. Lee Shapiro. Dr. Shapiro is Professor of Medicine and Director of the Scleroderma Center at Albany Medical College. He also serves as the Chief Medical Officer of the Stephan's Scleroderma Foundation and has been on the Medical Advisory Board of the Scleroderma Foundation's Tri-State chapter for 30 years. He was honored nationally by the Scleroderma Foundation in 2016 as Doctor of the Year for his many contributions he has given to our scleroderma community. Welcome and thank you for joining us today, Dr. Shapiro.
Okay. Thank you, Carrie. I'm going to speak on coping with both a pandemic and scleroderma, and I want to emphasize the word coping. I'm not going to be talking about enduring or suffering through or simply surviving this era, but coping with it in a more positive way. I have no disclosures or conflicts. And a quick outline, I broke the talk into 4 parts. The first is the impact of COVID-19 on the health and health care of individuals with scleroderma. The second is on scleroderma as it impacts COVID-19 prevention, including vaccination. The third is what to do if you have scleroderma and get COVID-19. And the last section will be brief on the impact of COVID-19 on scleroderma research. So the first issue, and it may be the only negative slide, is just to talk about the most common manifestations: anxiety and fear and isolation. And anxiety can show up in many ways as worsening of your shortness of breath, chest tightness, rapid heartbeat, fluctuations in your blood pressure, worsening of your heartburn or bloating, change in your bowel habits, worsening of Raynaud's, weight change, either increased or decreased, sleep disturbance, muscle pain, and depression. None of those is good. And if they don't reflect more active disease, but simply your state of mind, then there's certainly great hope that with coping with our era better, these can recede. And the same thing with isolation. We'll talk about how you might feel less isolated. First, in terms of the impact on healthcare, there's certainly been issue of transient loss of access to all sorts of healthcare, whether it's your primary physician, your rheumatologist, to your dentist, to physical and occupational therapy, to obtaining pulmonary function test or echocardiogram or simple lab testing. And now, even though these facilities are generally open, there may still be limitation due to your fear of infection or exposure, leading to neglect of medical and dental therapy and of testing. One way around that fear is utilization of telephone and televideo visits in lieu of inpatient visits. This obviously works better for some providers than others. It won't work at all with your dentist. Now, virtual visits have pros and cons, and they are almost certainly here to stay in some form because of the pros. They're so easy to accomplish. You don't need to arrange for a ride. And in some ways, in one way at least, they're better than the in-person visit in that you don't have to wear a mask and we can see your face. We might be able to understand you better. And so there's this facial interaction, which isn't still possible in the face-to-face visits. But there are more negatives, especially when it's a visit with your rheumatologist in terms of what is missed. That we cannot assess any change in your skin thickening. We can't tell that your fingers are cold. We can't examine your pulses. We can't assess your joints for the presence or absence of tendon rubs. We can't accept grossly by, if you put yourself through range of motion, get a good assessment of your mobility, your strength, of your heart or lung exam, and those things that we try to notice before and after a visit, how well you walk in and out of the office or climb on and off the examining table. If you're just sitting in front of your computer, we're going to miss all this. There are also a bunch of challenges with in-office visits that weren't there before. The first is wearing the mask. It makes it difficult to read each other's facial expression and sometimes to understand each other. And there is a little bit of literature on that, that if you communicate in full sentences, it's much easier to grasp your meaning than if you talk in just a single word. If you come alone, but always previously were accompanied by your spouse, a friend, a sibling, or a child, the visit might feel very different because you've lost support, you've lost someone who will raise issues, and you've lost someone who will listen to what's discussed and help you remember. Now, this may be corrected in some offices by the ability for your spouse or friend or sibling to dial in and be present at least by phone and take part in the discussion at the end of the visit, or to raise issues that you may have forgotten. It's also important when you're there by yourself to perhaps have more in writing at the end of the visit than was formerly the case, so that you can remember all that was discussed. But another challenge is that there are new topics related to the pandemic on top of all the old issues. And our time in terms of length of visit hasn't changed because of the pandemic. So it's become very difficult to cover not only all the issues related to the scleroderma or other aspects of your health, but also to cover all the topics that almost everyone has related to the pandemic. Questions about the disease, questions about the risk of medication, work safety, increasingly questions about vaccination and efficacy, and concerns about mental health, and questions about whether it's safe to continue with present medications or safe to have lab testing and other procedures done. Moving on to prevention, masks are generally well tolerated. They don't lower the oxygen level, but in individuals with pre-existing lung disease, the N95 masks, the most tight-fitting masks, also the most effective masks, may increase the work of breathing and may increase carbon dioxide levels marginally. But a lot of people say they feel that the work of breathing has increased with almost any mask. And truthfully, there's virtually no literature out there for me to address about that. Really just what I've said there. And as I mentioned, speech may be muffled and better communication achieved speaking in sentences rather than single words. Of course, if you're going to wear a mask, you should wear it correctly. And this is a photo on the side of the governor of Ohio. And I know he knows better, but it's not protecting him or those around him if the nasal openings aren't covered as well as the mouth being covered. Now, just today, I passed the medical office with this sign of what approved masks are, only cloth or disposable surgical masks. Now, I know there are a lot of states where there's a lot less compliance with masks than in New York State. But in New York State, recognizing people are compliant, I guess the health authorities have decided to step it up a bit. And all these other masks, which you commonly see, are not approved in some hospitals or some offices. Just the cloth or disposable surgical masks. The N95 masks, which are the most effective, may be in short supply, and presently they have been largely restricted to use with healthcare providers, so the supply isn't exhausted. But I don't know if any other state has developed this level of restriction in terms of not only should you wear a mask, but this is the mask you should wear. Now, if you truly can't tolerate a mask, you still don't want to spread anything that might be exhaled from you. So the recommendation is to use your forearm or your elbow if you have to cough or sneeze, to at least protect those around you to some degree. Now, we've all familiar with the guidance of hand washing, but there are a lot of issues in individuals with scleroderma, almost all of whom have involvement of the digits with Raynaud's or with skin thickening, with decreased mobility, with digital ulcers, with calcium deposits, or with sensitivity of the fingertips. So with frequent washing, there's going to be drying of the skin, especially if you use the hand sanitizers, which, to be effective, must contain 60% alcohol or more. Washing in any circumstance may cause chilling of the digits, provoking Raynaud's, or aggravating the pain of digital ulcers. And really any rough handling of the fingers may increase pain related to calcinosis. So to decrease the frequency with which you must wash your hands, if you're going to the grocery store or other shopping trips and you have ulcers on your fingers or very sensitive fingertips, this double combination of cotton glove beneath rubberized glove probably offers the greatest degree of protection and comfort, and without protecting your fingertips from abrasion. The third component is social distancing, and just about all of Edward Hopper's pictures look like they show someone during this pandemic thinking of what they could do. If they could have friends over, they can certainly still go outdoors, but that season of spending a lot of time outdoors is coming to an end in a lot of the country, especially for those who have cold sensitive fingers. So what to do? Well, here I got help from one of my most thoughtful patients who feels that many of you who have been coping with scleroderma for years may be better equipped to deal with this pandemic than those who have not experienced the trials of scleroderma. That from time of diagnosis, you've learned to deal with fear, to live with uncertainty regarding the disease course. You've established self-care routines. You've been resourceful and inventive. And you've learned to be both cautious and assertive to reduce risks and to make sure that you protect yourself in settings outside your home. And hopefully many of you have already mastered relaxation techniques to stay calm. This can be in many, many different forms. So tell yourself, I am resilient and I can get through anything. I learned in the preparation of this talk that there actually is a federal agency devoted to the behavioral health of the country, but I never heard of this agency. And it's perhaps because from the name you would think it's focused only on those with substance abuse problems. It's the SAMHSA, Substance Abuse and Mental Health Services Administration. But when you look at their purpose statement, it is really to be the agency that deals with behavioral health. And so they have several publications that may be just what you need for tips in terms of how to deal with this pandemic from the point of view of mastering your anxiety, worry, or fear. But unfortunately, almost no one has heard of them. They don't have the profile of the CDC or the FDA. From their booklet, I took these elements of first understanding the risk, which means also not overestimating the risk, being your own advocate, speaking about your needs, educating yourself. Some may be lucky enough to work with an employer who is in a position to help reduce financial stress, and especially connecting with others. I want to move on to vaccination issues in scleroderma. We don't know when these vaccines will arrive, but we know it's going to be soon. And for many of you, I'm sure you could feel it couldn't be too soon. But because there are so many different companies working on this and working on different vaccines, we're probably going to have a multitude of options in the near future. Should you get vaccinated? Well, I would say absolutely yes. We can talk about already benefits of influenza vaccination. That flu vaccine decreases mortality during influenza outbreaks. It decreases the risk of hospitalization for influenza-related complications, and it decreases the risk of influenza. So we're hopeful that with COVID-19, a vaccination will accomplish all three of those items as well. One question, if you have an autoimmune disease and you're on immunosuppressive therapy or you're older, is how to increase response to vaccination. So no vaccine results in 100% efficacy. One approach would be to vaccinate all household members, and those who don't have an autoimmune disease, who aren't on immunosuppressive therapy, or who are younger, would be anticipated to have a greater likelihood of response. So in all circumstances, your spouse should certainly be vaccinated because in-household transmission is probably the likeliest of all. If one person in the house is infected, then there's very high risk others in the same household will get infected. Now, I don't know, I'm not privy to what the strategies are of the vaccine makers, but with flu vaccine, a higher dose is given to individuals who are 65 or older because of diminished response. And the same might be applied with this vaccine, I don't know. And some of these vaccines will require booster injections, and I don't know how many for which it will be one booster or two boosters. This is already the case with the shingles vaccine and with hepatitis B vaccine, that one injection may not be enough. And another approach is the use of adjuvants. So the new shingles vaccine called SHING-RX has an adjuvant in it. Adjuvants are molecules which, in combination with antigens, increase the immunologic response of the recipient of the vaccine. Now, when the shingles vaccine was introduced, there was some concern because of this that there would be induction or enhancement of autoimmunity, that it might cause flares in individuals with rheumatoid arthritis or lupus or any autoimmune disease. But this has proven not to be the case. So I do not know which vaccines, if any, employ adjuvants, but with history to date with the SHING-RX vaccine, it doesn't appear that this would be so worrisome. But a bigger issue is the medications that you take. Will they diminish your response? So which drugs can suppress your response to a vaccine? Many don't appear to, but the one that the literature clearly states can do so is RITUXAN. And RITUXAN is a long-acting medication. So if you are on RITUXAN, this is a discussion to be had between you and your physician regarding the timing of the vaccine, whether the infusion of RITUXAN should be delayed or whether any other medication should be employed in place of the RITUXAN. There is literature, and again, it's related to pneumococcal vaccine, to influenza vaccine, that other drugs may have a lesser degree of suppression, notably MYCOPHENOLATE and METHOTREXATE. These are shorter acting medications, and with METHOTREXATE, it's felt that holding the medication for 2 weeks after vaccination brings the response rate close to what it is in individuals who are not on METHOTREXATE. There's no clear timing guideline for MYCOPHENOLATE, but it's probably comparable, holding it for a couple of weeks. We really wouldn't want to interrupt it longer than that in individuals with active interstitial lung disease. So RITUXAN, again, is the most important drug of concern when it comes to vaccination. It can severely suppress the humoral or B-cell driven response to vaccination. And those vaccinated, again, looking historically at those vaccinated for influenza 6 months or more after infusion, had a better response than those vaccinated 4 to 8 weeks after RITUXAN. Repeated courses of RITUXAN didn't seem to cause an even greater degree of suppression. And the other concern with RITUXAN is that if you are unlucky enough to develop COVID-19, you won't have as vigorous humoral response, B-cell response, and may have a false negative test for COVID-19. So recommendations are, if possible, to receive immunization at least a few weeks prior to immunosuppressive therapy. If you're not on anything, if you're newly diagnosed or if you've just been diagnosed with interstitial lung disease thought to require therapy, to get the immunizations first. And with RITUXAN, vaccination should ideally occur at least several months after the last dose, and at least 4 weeks prior to a subsequent dose. Again, with methotrexate and mycophenolate, they have a much shorter half-life. We go historically by what happened with influenza vaccine, that there was a decreased response. There's no consensus, but holding the drugs for 2 weeks after vaccination may increase the response. Moving on to what to do if you get COVID-19. So there are many different symptoms, and it turns out that if someone has many symptoms, 5 or more, they are more likely to have prolonged illness. The symptoms may develop anywhere from 2 to 14 days after close exposure to the virus. And I put a little asterisk to indicate those symptoms that you might already be feeling. So it's really being a very good observer of your own health so that you can recognize, even if those symptoms are usually present, whether there has been a quantitative change, something that you should not sit at home in denial that nothing is going on, but recognize that the way you feel is not your usual self and that you really should be evaluated and tested. But fever, chills, or chills certainly should attract your attention. That's not a common feature of scleroderma. Cough, if it's changed in character, become more frequent, is of new onset, especially if combined with an increase in shortness of breath or difficulty breathing, with an increase in fatigue, with an abrupt increase in muscle or body aches, with new onset of headache, again, not a symptom of scleroderma, with new loss of taste or smell sensation, new sore throat, congestion or runny nose, and COVID-19 can present with GI symptoms, nausea or vomiting, or diarrhea. And again, diarrhea might develop quite abruptly in someone with scleroderma from small bowel bacterial overgrowth or some other cause. But if it's accompanied by any of the other symptoms, don't assume it's the same old, but really pursue testing. So the CDC has made some guidelines for when you should seek emergency medical attention. And these are not scleroderma specific. And again, I've put a little asterisk about those that might be a judgment call on your part because of existing issues. So trouble breathing, well, many of you have trouble breathing on a daily basis. But if it is abruptly worse, and especially if it's accompanied by any of those symptoms mentioned previously, you should not ignore it. Persistent pain or pressure in the chest, new confusion, inability to awaken or stay awake, and a bluish lips or face, not cyanosis of your fingers, blueness of your fingers, because that probably occurs commonly, but we're concerned whether the oxygen level has really dropped. Now, I have to point out that those of you who live alone are at particular risk of failing to recognize what's newly wrong with you. And as you can see, especially because one item on the list is new confusion, and another is this inability to stay awake. So hopefully someone is checking on your status, especially if you live in an area of a high rate of infection, that someone is calling you on a daily basis. And if that's not the case, I highly recommend it. So risk factors for more severe infection. Well, we know that age is. Obesity, there is some dispute in the literature, but I kept it on the list. Pre-existing lung or heart disease. And again, many of you have some degree of lung disease. Diabetes, prednisone greater than 10 milligrams a day, but not other immunosuppressives, and individuals in the Black or Latino population. Now, anyone can get COVID-19. So if you're on immunosuppressive medication, if you're on prednisone, it doesn't mean you're more likely to get the infection. And prednisone is the only immunosuppressive therapy, and it's at higher doses, not at 5 milligrams a day, where there is developing evidence that it puts an individual at greater risk of more severe infection. What to do if you get COVID-19? Well, one, inform your rheumatologist. Now, that might seem like a strange thing to do, but there are parallels. So one is an individual presenting in the emergency room with new onset severe hypertension, could be scleroderma renal crisis, and it's actually the rheumatologist who's most likely to direct that individual to appropriate therapy or direct the emergency room doctor to appropriate therapy. Well, it turns out when someone is hospitalized with COVID-19, from one recent report in New York City, only about 10% of the time did the rheumatologist know that their patient was hospitalized. And it turns out the rheumatologist may have a lot of valuable insight and input to make in terms of the management in the hospital. So they need to know. Do not stop prednisone if you're on it. You can cause flare of symptoms. You could cause what's called adrenal crisis by suddenly taking away the prednisone. So it'll make you sicker, not healthier. Do not stop your ACE inhibitor. There is no evidence that any of these agents contribute to increased risk of infection or poor outcome. Do not stop your proton pump inhibitor or your H2 blocker. Your heartburn will rapidly get worse. And there's no need to stop hydroxychloroquine, but there's also no evidence of protective effect. But if you are on any of the following immunosuppressive drugs, you should hold them. And that would include methotrexate, mycophenolate, which could be Cellcept or Myfortic, azathioprine, which is Imuran, CITED, which is cyclophosphamide, tocilizumab, which is Actemra, RITUXAN certainly, and tofacitinib or Xeljanz. If you get COVID-19 or your spouse or other member of your household is infected, you should follow the same precautions as if it were already a documented infection in you. That you should assume you have a very high risk of having the infection, and you should stop those immunosuppressive medications. Again, not the prednisone. The duration of the interruption of therapy must be guided by your physician. Again, if you are hospitalized, inform your rheumatologist. They are probably, or we are probably, the last doctor the ER doctor will think of calling. They might call your pulmonologist, your cardiologist, your gastroenterologist if you present with GI symptoms, but they don't call your rheumatologist. And be prepared, or prepare your family members to be an educator. In the hospital, it's so often the case that you will be the individual in the room who knows more about scleroderma than anybody else. And scleroderma can impact how you are assessed and how you are treated. So one big issue is accurate oximetry or measure of the blood oxygen level, because that is such a key in terms of who needs to be hospitalized, who can go home, who needs more aggressive treatment. You want to avoid, if possible, arterial blood gas, which we'll talk about. And if you know you have lung disease, it wouldn't be a bad idea to obtain even now a disc of your CT scan or chest X-ray and keep it in your possession, so that if you ever have to go to the hospital and it's a different hospital from where you had the imaging, they will have access to what your lungs looked like before you got any infection on top of it. And this is extremely important. It's important just the same way if someone has a lung nodule, before they're put through a lot of tests to find out what the lung nodule is, if they have imaging from 2 years before that shows a lung nodule was there, we don't get feeling as if we have to intervene. So the same thing if a chest CT shows that 6 months before or a year before you had exactly the same lungs, that would be comforting to you and comforting to a doctor taking care of you. So one feature of scleroderma lung disease can be these ground glass changes. They can also occur in COVID-19. And in COVID-19, it can progress to opacification, areas of greater consolidation of the lung, as seen over on the right. And again, this could be the image of someone with scleroderma. It could be the image of someone with COVID-19 who never had scleroderma, or it could be someone with COVID-19 who had scleroderma, and you wouldn't know, is it old or is it new, unless you had access to those old images. So oximetry is reliable in individuals who have normal circulation of their fingers, who have warm fingers and normal pulse exam. But if you're someone who always has cold fingers, white fingers, blue fingers, poor pulses, oximetry can cause unwarranted concern in you or in the physician who's examining you at urgent care in the emergency room. The level may come out appallingly low, and there may in fact be a low oxygen level at the fingertip, but not in the body as a whole. So I saw someone just today who told me that her pinky is the one finger that gives a reliable reading. And she knows that, and she can tell someone that. And if she's ever severely ill, it's good that her husband knows that as well, so that he can direct people. So if that doesn't work, you get a low reading. There are other ways of measuring oxygen saturation. One is a forehead probe. The other is a probe on the earlobe. And these usually give reliable readings in individuals who may have very severe compromise of digital blood flow. So keep that in mind. Now, the arterial blood gas should be avoided if at all possible. The arterial blood gas does measure the arterial oxygen and also the carbon dioxide level. And it is done, and it might be warranted if it appears someone's having rapid deterioration in their lung function, and if they are retaining carbon dioxide, whether they need assisted ventilation. But as a first step in someone who's not so critically ill, it can cause more problems. And in about 10% of individuals with scleroderma, there can be there are two arteries going to the hand, the radial artery and the ulnar artery. It's the radial artery that is usually employed for this arterial blood gas, with this needle put into the radial artery. But if you're one of those 10% who have an occluded or severely narrowed ulnar artery, and this test is done and causes spasm in the radial artery, it could cause profound and prolonged interruption of blood flow to the fingers, and result in ulceration and events days and weeks after the blood gas. So yes, there are situations in those who are truly critically ill where it might need to be done. But in individuals with scleroderma, it should be avoided whenever possible. Now, As you well know, and I'm not going to discuss it at length, in severe disease, immunosuppressive drugs may be employed. They aren't antiviral agents, but they suppress the so-called cytokine storm, which may be the source of inflammation in the lung, but also in the heart, in the central nervous system, in the skin. And Decadron, which is a potent steroid, has been found. So even though high dose steroids prior to infection may increase your risk of severe infection, almost paradoxically, if you have severe infection, high dose steroids may be life-saving. Also, tocilizumab, which blocks the activity of interleukin-6, which is known to be the mediator of a lot of the inflammation in these cases of cytokine storm or severe COVID infection, may be employed. And again, a rheumatologist is an expert in use of this medicine. And anakinra or Kineret, not used in scleroderma, but used in other rheumatic diseases. It's an interleukin-1 inhibitor. So these and a variety of other immunosuppressive drugs are currently in use for those who are critically ill with COVID-19. Now, post-COVID-19 infection is becoming a bigger issue. And indeed, there's a term now called long COVID. And in about 1 in 20 individuals with COVID-19 infection, there may be persistence of symptoms for more than 8 weeks. And in a smaller fraction, much longer. Even if you didn't have pre-existing lung disease, lung function may not return to baseline. And post-COVID-19 clinics are being established. Our knowledge base is increasing by day or by week. So we really don't know the long-term prognosis, but we do know that there are individuals who months after the infection are still not back to where they were before. It's a minority, but it certainly can happen. Also, because there's so many questions we can't answer, it is important that we gather as much information from as many people as we possibly can. So ask your physician if you're one of those unlucky enough to have COVID-19, even if it's mild, to report your case, and it's an anonymous report, to the COVID-19 Global Rheumatology Alliance website, rheum-covid.org. And they have already enrolled about 7,000 individuals who had COVID-19 in the setting of a rheumatic disease. But of that, only several dozen had scleroderma. So there's starting to appear case reports in the literature about the experience of individuals with scleroderma with COVID-19, but the numbers are tiny. So it's important that we gather as much data so we can give answers to those who might get infected in the future in terms of, in the setting of scleroderma specifically, what are the complications that occur that may make you differ from the general population or those with other autoimmune diseases, and what drugs put people with scleroderma at greatest risk and in the treatment course of the greatest benefit. So I'm going to very briefly talk about the impact of COVID-19 on research. The initial impact was a negative one because many drug studies were delayed or interrupted because it was impossible to have individuals come for their regularly scheduled study visits, monthly or every other month, or even if the study center was open, that they didn't want to come. So it certainly initially slowed down research. But there have been positive effects as well, in that COVID-19, we now know, is in some ways what's called an endothelial tropic virus, that it causes damage to the endothelial wall, and that's responsible for many of the manifestations, that a lot of the inflammation is in the blood vessels in these organs, whether it's the lung or the heart or the skin. And the result is that COVID-19 may lead to advances in understanding the pathology and treatment of the microvascular disease in scleroderma. A shared feature is damage to the lining cells, the endothelium of small blood vessels. And there is a wave of articles on this topic appearing, of which I've just shown a few. So when the pandemic is conquered and all these labs have moved on from COVID-19, I hope we can get many of them to focus on scleroderma. So the incredibly rapid progress in understanding and treating COVID-19 demonstrates the power of awareness and adequate funding to solve problems at warp speed. Warp speed hasn't really been applied to scleroderma, but I'm hoping that the next stop of this spaceship will be, or the next launch of it will be with scleroderma research. So that's pretty much all I have to say. I wanted to acknowledge my brain trust of Jessica Farrell, who's a pharmacist who works with me, Celeste Freeman, an occupational therapist who's going to be lecturing to the National Occupational Therapy Organization regarding management of scleroderma, and to Lyndon Meenan, whose thoughtfulness contributed to several of these slides. And I want to thank you for attending, and I ask that you stay well. And a lot of that is in your power, certainly in terms of your mental health, and to stay connected, because that may be the key to your mental health. And these are helpful websites. The CDC, despite all the issues in the news about conflicts, it's a wonderful source of information at this website. And the organization of government that I never heard of, the Substance Abuse and Mental Health Services Administration, which focuses on behavioral health. This is their website, samhsa.gov, and the COVID-19 Global Rheumatology Alliance, rheum-covid.org. Thank you very much.
Well, thank you, Dr. Shapiro. That was a fantastic presentation. It's great. It looks like the attendees have taken the opportunity to submit some questions. We have National Team Office member Angel Soto, Programs and Services Associate, here to facilitate our question and answer segment. Angel?
Thank you, Carrie, and thank you again for that wonderful presentation, Dr. Shapiro. I'll get right into some of these questions. The first one we have here are, we understand that as a vulnerable population, will be urged to get the vaccine first. Are there any issues or unique complications that would make us want to wait a little longer to get the vaccine, or should we get it right away?
Okay. Oops. Well, this is really a difficult question to answer. I think one concern is that will it work in you, as well as in someone who, especially those of you on immunosuppressive medication. And so I certainly think you should encourage all your household contacts to get the vaccine. And yes, if it were just as with the flu vaccine, this disease, when it has its most catastrophic complications, affects the lung. And if your lung is compromised, I don't think that you should long delay. I think that the bigger concern is whether the medication, whether the vaccination is effective in you. And there is going to be, from recent regulations, at least a several-month period of observation of those who've been in the trials before any vaccine is released. So I think, weighing pros and cons, that if you have compromised lungs, you should absolutely get the vaccine, that your risk is greater without than with. So that's as far as I can go. I certainly know that if you're an anti-vaxxer and you feel very strongly, it's the same situation as if I feel someone would really benefit from a medicine, but they think that medicine is going to be a poison. It's not going to work. And so you have to get yourself in a positive frame of mind and not dread receiving the vaccine.
Thank you, Dr. Shapiro. The next question is, I know that the N95 surgical mask is the most effective, but it can be a little constricting, and the cloth masks seem to be more comfortable. How big of a difference is there in efficacy between these masks?
Well, I don't think I'm qualified to answer that, but again, the concern with the mask is the role they play is more protecting others from you than protecting yourself. So the much bigger issue, regardless of the mask that you wear, is, are the people around you wearing a mask, any kind of mask, and how close are they to you? So I think that in any environment you go, wear a mask for sure. I don't think it's critical that you wear an N95 mask, but maintain some distance. And this is an issue, I forgot to mention it in the office, that when I'm most at risk is when I have someone remove a mask so I can look in their mouth. It's too easy now to just forget that, leave the mask in place. And I have had to learn that that is the worst time for me to make a joke, because I tell them that I feel like I'm violating the law to have them remove the mask, and that sometimes provokes a laugh, which is usually just inches from my face. So it was bad timing. So I have a mask on, of course, and if I'm going to make a joke, I should put a shield on. So the same thing at a dental office, that the risk is much greater to the dentist than to you, because again, your mask is off. So I do not think it's critical that you get an N95 mask, but I think it's critical that you make sure that everyone around you is wearing a mask.
Thank you. That was very well said. And I'm glad, your jokes are still going strong. The next question we have is, for individuals who work in higher risk areas, so for example, a school teacher, should we still be working in the classroom, or is this too high risk?
Okay, well, there certainly are individuals that I have taken out of work, and it's been a combination of a high-risk profession with a high-risk patient. So I have taken someone very reluctantly out of work. That is, he was reluctant to go out of work, who was a bus driver, one of the most exposed occupations. He had scleroderma, he had lupus, he was on prednisone, he was on other immunosuppressive drugs, he had lung disease, and he was African American. So I said, you have a combination of risks and you have a risky profession, and I have to take you out. And I've done the same with a grocery store manager who was on immunosuppressive medication, and again, lots of contact with people who may not be so compliant. So I think just like they say, education is kind of a local matter, I don't want to quite go there with the teachers, because the arrangements in different schools have been very different. The community outbreaks have been very different. The precautions taken have been very different. And there certainly have been schools, and I think in New York City, where the infection rates, even back within school teaching, have been surprisingly low. So there are more school teachers than any other profession, perhaps, but the circumstances are so variable that I can't really give an answer. I think that's in that instance, I have to bounce it to your physician who knows what the local circumstances are to give you better advice.
Of course. Thank you. And when reviewing data, have you seen anything of note in regards to OFEV and interstitial lung disease?
No, I have not. Again, I think that the numbers of people on OFEV, I wouldn't expect it to be a big issue with vaccination. But in terms of how people, what's happened to them if they've gotten COVID-19, then the numbers must be tiny. And if there are any reports, it might be through the company, the manufacturer, but I haven't seen anything about it. Zero.
Thank you. Has there been any pertinent data or new data on whether the virus is able to live on surfaces, packaging? Should I be worried about, eating out, whether it be outside or inside of a restaurant? Yeah, I've just been hearing a lot of conflicting data.
Okay, well, there are a lot of different questions in there. And in terms of the survival on surfaces, I'm no expert. I'm a rheumatologist, not a virologist or a public health doctor. So, and I have to say that it's a little hard to delve into the literature and know what's reliable or not. That if you go to clinicaltrials.gov to see how many studies there are of COVID-19, there are, as of yesterday, 3,663. So there is an awful lot going on. As far as the restaurant issue, well, again, I think if you view yourself as someone at high risk, if you know you have factors that if you got COVID-19, you would be at high risk of a bad outcome. If you're someone with significant lung disease on immunosuppressive therapy, if you are older and have hypertension and have diabetes, or if you're obese because you've already eaten out a lot, that you should not eat out, because you could eat outside, but and again, it's going to be local circumstances that are you in Vermont where there's hardly any COVID-19, or are you in Montana or North Dakota and you're again, what you do has to be individualized, and how they space the tables in the restaurant and whether there's adequate social distancing. And but if you're at high risk, again, anyone can get COVID-19. Certainly some of us on this webinar will, the odds are. And for most people, it will be a brief event, may be very unpleasant, lasting, a week or a couple of weeks. It won't be an enduring illness, in contrast to scleroderma. But the prospect of it can be terrifying or unsettling. But if you got it, you're putting yourself at high risk, then I think you want to take less risks as far as exposure.
Perfect. We've got time for about 2 more questions. So the next question here is, do you know if the COVID-19 virus can be transmitted through the eyes or ears?
Well, the ears I can't comment on, but the eyes are a concern in terms of which why we all are wearing goggles with patient encounters. So, but the ears I don't know.
And the final question is, have you found any unique data or research articles specifically related to patients living with scleroderma that have contracted COVID-19? And where could we find those?
Okay. Well, there are, at this point, there are a couple of papers that are recommendations or concerns in regard to if someone with scleroderma gets COVID-19. And they were a source of some of what I discussed, but there are probably only so far less than half a dozen case reports, and they are individual series or 2 or 3 or at the most 4 patients with scleroderma. And if you go to PubMed.gov, PubMed.gov, and just type in scleroderma and COVID-19, they will pop up. There's not an overwhelming number of such articles yet, but they are readily accessible to you. Some of them are, because it'll indicate not just the abstract of the article, but it will show if free text is accessible. And so definitely with some of those reports, they are accessible to anybody.
Excellent questions. Thank you, Angel, for facilitating that segment. Dr. Shapiro, any parting comments as we wrap up today's session?
Just, I want to emphasize the importance of reaching out at this time. I think that attending virtual university is one of the best things that you can do, or attend as many virtual universities, virtual book clubs, other virtual events that bring you into contact with others, because that's how we're going to best get through the dark, cold months that are ahead of us. And again, I want to emphasize that when we're past this, that I think there really may be an incredible acceleration of understanding of scleroderma, especially vascular disease and scleroderma, and new approaches to the disease. So there is a silver lining. Again, reaching out, staying connected is so incredibly important right now.
Well, wonderful. In closing, I would like to thank Dr. Lee Shapiro for being such a strong champion of our mission and for sharing your time and expertise with us today. Thank you to our attendees that logged in or dialed in today. And a special thank you to our Diamond National sponsors, Actelion Pharmaceuticals US and Boehringer Ingelheim, and our corporate sponsor, Corbus Pharmaceuticals and Horizon Therapeutics. As a reminder, we will be hosting these virtual university webinars weekly. Next Wednesday, October 28th, Mary Crow of Care Dimensions will be joining us to speak on making decisions when it matters most, conversations about healthcare proxy, 5 wishers, and more. As always, stay connected with us through our website, Scleroderma.org, and our social media outlets to stay informed on all our virtual university patient education series, as well as our great chapter virtual events happening across the country now. This will conclude today's webinar. Be well and have a great day. Thank you.
Thank you.